next and last talk that will be on post-menopausal osteoporosis by Dr. Tabinda Dugal. She is from National.
Thank you very much, and I'm really grateful to PSIM for inviting me here, and I'm really humbled to be standing here and talking to all these learned people already. So this is something which is very close to my heart, and I would like to have a show of hands from the male physicians in the audience. How many of you think that postmenopausal osteoporosis is important or something that is worth discussing? Okay, so yeah, a few things. So I'm preaching to some of the converted anyway, but the ones who haven't raised their hands, I would like to discuss how important it is to have healthy bone structure in women, because they are living longer and they have got productivity in those years, and to survive a hip fracture, and it's a difficult thing, and also to regain function is also difficult after that. So prevention is the key here, and I'd be talking more about prevention rather than treating it. I think that is the key time to do something about it, is around the perimenopause time. So this is my disclosure. And basically the scope of the talk would be, what is osteoporosis, why is it important, and how do we treat it? So 3 main topics, just to make it simple. So this is the definition of osteoporosis, as you all know. It's a condition of skeletal fragility due to progressive bone loss. And basically what I wanted to emphasize also was that not only is the bone mass reduced, it is the actual structure of the bone that deteriorates. And we need to realize that it's not simply reliant on bone mineral density when we measure it on DEXA. It is quite reliant on the trabecular quality as well. So we need to bear that in mind when we are assessing the risk of the patient that we would be treating. So this is a simplistic illustration, a cartoon of a femur that is healthy and the one that has got osteoporosis. As you can see, big holes in the trabecula. The cortex eventually gets involved, but initially it's the trabecula that form the scaffolding inside with collagen support that gets affected initially. So, so it is the interval of relatively rapid bone loss at menopause, resulting in significant deterioration, as I said, in trabecular and even cortical microarchitecture. So in women, there is a sudden loss of bone quality and bone mineralization at the time of menopause. As you can see, the blue line denotes the males, and they are lucky to retain their bone mass dependent on the testosterone that they have. And the women have a sudden sharp fall in their bone mass at between 50 and 60. And this is the time where we have to clinch it, rather than somebody coming in with a fracture femur and then us trying to treat their osteoporosis. So the findings that I am basing my talk on comes from a very long study, which is called the SWAN study. It was a study of women's health across the nation. It informed us about the bone loss across the menopausal transition. So there were thousands of women in this study who had not quite entered the menopause yet. They were in their perimenopause state, and they were followed up for 20 years. So there were other indicators, other outcomes from this study as well, but the main outcome that was important to this talk was from 5 centers. It was bone mineral density cohort. So the age range was 42 to 52, and they've had a period at least every 3 months. They had a rapid bone loss from year 1 to 2 before entering the menopause, and 3 to 4 years after the final menstrual period. So actually the deterioration starts way before the cessation of period. So we really have to pick the patient at that time when the bone mineral deterioration hasn't quite started. So in the 6-year period spanning the transition, the menstrual transition, menopausal transition, and early post-menopause, the cumulative bone mineral density average loss was about 10%, so which equates to -1 T-score. So quite significant deterioration in the bone mineral density. So this is also an illustration of what I've said before, that these 2 patients who were picked for trabecular quality, one is from the placebo group and the other were given residinate. So you can see at baseline, premenopausally, both they have got an okay kind of trabecular quality, but in 1 year, the placebo patient who is not on any treatment has significantly deteriorated trabecular quality, whereas the one who's on residinate has got some trabecular. So in essence, the placebo, if you measure their bone mineral density, there was only about -2% reduction. So 2% reduction, but trabecular quality really going down. So the other important factor is the bone mineral density at the time of the final menstrual period. This is an independent factor regardless of decline, how quickly the decline will be. The bone mineral density at which they enter the menopause would be so important to determine how they reach that fracturable range of bone mineral density. So we have this very, very narrow margin of menopause transition, and it's a time-limited opportunity that we should take for short-term anti-resorptive therapy to lessen a woman's risk of fracture. So this might be a novel concept that at the time of perimenopause, if we give a short course of anti-resorptive agents, like the bisphosphonates, for about 2 years, we will conserve the bone for a lot longer unless we choose to ignore that time. Two very important factors, family history of osteoporosis and bone mineral density at the time menopause, would identify the women who are at risk of developing osteoporosis. So we have to identify the person who is going to develop osteoporosis, because initially it's so silent that we really cannot identify them without classifying them. So these are some of the things that help classification of the high-risk patients, and this was taken from this osteoporosis journal book published only last year. There's also been some noise about FSH, and that the FSH, rather than estradiol, FSH levels, high FSH levels at menopause cause the bone mineral deterioration rather than the estradiol lag. And the thing that supports it is that, you know, higher levels of estradiol are required around perimenopause to maintain levels of estradiol. So the person may have relatively normal estradiol, and sometimes even higher levels of estradiol, which shouldn't quite be responsible for the bone resorption. So there is this theory that FSH might be responsible for some of the bone resorption. And there is this concept of the role of anti-FSH antibodies that is being checked out as we speak. So we should watch this space. These are borrowed slides from someone, and basically it is to prove that if the person enters the transition of menopause with a normal bone mineral density, which is the top line, and the bottom line is the FRAC score. So they will actually meet -2.5 or -2, where they mostly fracture patients are diagnosed with osteoporosis and maybe have higher risk of fracture at about age 75 to 80 if they enter menopause with normal bone mineral density. And contrast, if someone enters a menopause with a lower bone mineral density, like -1.5 or -1, they will actually hit this target in their 60s. So they will be eligible for treatment at 65 already. So you have to see the patient at the right time, have their bone mineral density, and see when will they need intervention, if not before that. So also, age has been pandered around as a big risk factor for a long time, to say that, oh, age 65 or older, like we showed. But I think that the point is to pick up the younger women who are at risk, and I think that's where we are lacking, and that's where we are lagging behind. So anyone who's had previous fracture or has family history of osteoporosis, or they are thin, like below 57 kilograms, they might have a higher risk of having osteoporosis, so these patients should be investigated. So the guidelines that were made were when the DEXA scan was very expensive, and now I think it's quite commonly found and it's quite cheap, so we can actually screen more people rather than sticking to these criteria. So this is a tool that we can use. This is the osteoporosis self-assessment tool, and it should be around 2 for people. And if they don't fulfill this, then they can go on to have further investigations for bone mineral density. So why do we need to screen for osteoporosis after menopause? Because there is rapid bone loss. When? In the perimenopause, as I said. And how? Bone mineral density with DEXA. So after doing the osteoporosis risk score. And of course, we cannot underrate the importance of exercise and calcium replete and vitamin D replete, and to quit smoking if they're smoking. This is also a borrowed slide from a study that was done in Canada by Dr. Khan, and these are the people who were, the blue bar is on people who were on alendronate, and you can see that they gained about 4% in their bone mineral density, and the pink bar is patients who were not on anything. And this is a 12-month study, so it was a relatively short study as the bone span goes, because you know the bone gets replaced every 10 years. It's constantly being replaced and taken away. So, these patients were between 40 to 55 years, so the right perimenopause age group. So patients who are without osteoporosis, so they do not have osteoporosis, I think we should be proactive in preventing the osteoporosis by offering them HRT, like estrogen-based or combo with progesterone if they have a uterus, raloxifene, tibolone, which is licensed in some countries, not every country, and a short course of bisphosphonate. So they have been approved for prevention, all of these drugs are. Although estrogen, as I'll say later, it's not a drug that has been approved for treatment of osteoporosis. It's definitely approved for prevention of osteoporosis. So this is how the estrogen works. As you know, that it reduces the rank L. Rank L is the one that activates the osteoclast, and then the osteoclast differentiate and they start eating up the bone, simply put like this. So estrogen reduces rank L. The HRT evidence came from the WHI, and which is very ironic that the Women Health Initiative, actually less women started to take estrogen after that because there were some negative indicators. However, it did support the increase in bone mineral density after patients were put on HRT. So vertebral fractures, hip fractures, and total fractures were reduced by 34% versus placebo in a low-risk population. So these patients were low risk, but they were on HRT. HRT impact was not evaluated in patients with osteoporosis, and as I said, HRT is not licensed to be used as treatment of osteoporosis, rather prevention of it. And so this is also from the JOGC guideline from Canada. This is for the SERMs, like raloxifene. They also do the same thing, but in a weaker way, that they will reduce rank L levels. So raloxifene, as we know, is available for patients who have had, for example, gone through breast cancer and they cannot take any HRT or estrogen, they can be given this. It does support the vertebra, but not the non-vertebral fracture reduction. It's an estrogen agonist, but as I said, it doesn't reduce the non-vertebral fracture, so the hip fractures will still be an issue. So these are the various medications available. Alendronate, atidronate, which is a non-nitrogen containing, I don't think anybody uses it anymore, residronate, PTH, and zalendronate, commonly used. As you can see how much they reduce the vertebral fractures and non-vertebral fractures. So the risk reduction overall in hip fractures is in some, but not all. This is denosumab, which, as we know, is an antibody that binds with rank L, and this was the FREEDOM trial, which showed reduction, overall reduction in fractures on all sites, non-vertebral, hip, and other fractures. This is a cartoon that depicts how denosumab works. As you can see, it binds to the rank L and then reduces the amount of rank L that is there to activate the osteoclast. The bisphosphonates bind to the hydroxyapatite crystals, and they eventually kill off the osteoclast. So basically, the osteoblasts are outnumbering the osteoclast. So you can see in the corner, bisphosphonates are there as well. However, in contrast to bisphosphonates, which sit in the bone for a long time, denosumab doesn't remain bound to the bone for a long time, and therefore, when you stop taking denosumab, there is a sudden reduction in bone mass. So, as I said, it binds to rank L, it doesn't store, and there's bone loss after 1 month of stopping. And we know, lastly, I come to the anabolic therapy. So there's been some novel proteins identified. Sclerostin is one of them. It is a signaling protein which decreases bone formation. Estrogen reduces sclerostin by 50%. So giving estrogen, like in the form of HRT at the perimenopause, would reduce the sclerostin, the bone loss protein, by 50%. And in a similar token, raloxifene also reduces sclerostin. And we all know that teriparatide, which is a PTH analog, also is helpful in, is an anabolic hormone. But at the same time, it is catabolic, that it also does bind to the PTH receptors, and there's a little bit of eating away of the bone. So it is useful, but not as useful as some of the others. It does increase rank L, as I said, so, and helps with bone resorption. So this is teriparatide, the evidence about teriparatide. The yellow is the placebo, and the red is the PTH. So the risk reduction is about 65% with people who were on teriparatide with non-vertebral fractures in women who had postmenopausal osteoporosis. This was an 18-month study. So this is the new kid on the block, romosozumab. It's a monoclonal antibody to sclerostin. It's given by monthly injection. It's large volume, so it's given in both thighs. And there is, sorry about the typo, over 1 year, there's a dramatic increase in bone mineral density and reduced fracture risk. However, there is some reservation about it in patients who have heart disease. So you cannot, we don't know inhibition of sclerostin, what it does to the cardiac vasculature and the cardiac tissue, so it cannot be given to patients who have got heart issues. And a similar trial, in a similar token, and the teriparatide cannot be given to people who've had tumors, who have had cancers. There was this Vero trial in which teriparatide was compared to risedronate, and obviously it came back trumps versus risedronate. So this is a study from 2018. Romosozumab it's a 12-month study that was followed by anti-resorptive agents. So this is a clever way of doing it, that you build bone with anabolic, with romosozumab, and then follow it with bisphosphonates. So in patients who have high fracture risk, i.e. more than 20%, you have to give dual therapy. So build the bone and then give anti-resorptive therapy so that the bone remains. This reduces hip fractures, but as I said, there's a question mark over cardiac patient till further studies come through. This is a study between ramucimab and alendronate. So the blue is the ramucimab and the pink is alendronate, and I can say the risk reduction is about 37% with ramucimab as compared to alendronate, and it persists at 24 months. So this is the same thing in another graphical form. You can see that the widening between the two lines with improvement in the incidence of hip fracture. So whom to treat? People who have, we said that prevention was important. So basically identify your perimenopause patient and treat them. But if they've already got osteoporosis and they have hit the high risk mark, which is more than 20% risk on the FRAC scoring, then you have to treat them, like I said, through cyclical therapy, building bone, and then giving an anti-resorptive agent. So it applies to high and very high fracture risk patients. The intermediate risk fracture patients can get bisphosphonate. These are people who have a risk between 10 to 20%. This is also from Dr. Khan's study from the guidelines in Canada. As I said, you reduce the fracture risk through anabolic agents, and then keep going for another 12 to 24 months by anti-resorptive therapy to prevent bone mineral decline. And then they can get a drug holiday, and then you can repeat the cycle all over again. If the patients can't get anything they've had their cancer survivors and they have got cardiac issues, so you can't give them either, then you can give them denosumab. And if you give them denosumab, I think it has to be along with PTH, so they have to be started at the same time, and then they can work together. So this is what we should prevent, that women should remain in prime form, working, being useful, and not having things that could have been prevented. And with this, I am very conscious of the time, and I would like to end my talk. And thank you again. I'm really grateful for being invited to talk.